This is bifurcation strategies in left main PCI, which is
Imre, how are
supported
you?
by Biotronic, and moderator is Eve. I hope that Imre
is
and
there.
Wampros are on site. That's great.
No, Imre is not here. He is on the screen. Hello, Imre.
Hello.
Speaking. Nice to see you.
Good to see you after such a long time.
Hello to both of you. Thanks for...
Hi.
So we begin?
Yep.
And okay, this is a session of Biotronic. It's dedicated to bifurcation strategies in left main PCI. And the first speaker will be Robert Gill, who's speaking about left main PCI update of 2022. So only update of 1 year.
A couple of words regarding my attitude to this particular topic. You know, left main percutaneous treatment is again under very hot discussion, especially with cardiac surgeons. So therefore, taking into account so many aspects which are very important under the discussion, I choose only two. In first one, I would like. So this is. Oh my, sorry. This is not here. This is just a mistake. I'm sorry. So therefore, I would like to focus today on two aspects. The one is regarding, let's say, attitude to the protocol of treatment for left main, and the second one, let's say, a position of percutaneous treatment in respect to upcoming or ongoing new recommendations for myocardial bifurcation. So let's start with the first aspect or first topic. So we have to understand that every discussion on left main bifurcation treatment is very hot because this is a most important part of the coronary vasculature. 2/3 of myocardium is in jeopardy. In case of real problem with left main, there is no time to lose. And in acute coronary syndrome patients, this is not a way to optimize which is better, percutaneous or surgical. It's important to restore the flow. The second very important issue is the importance of side branch, which is mainly circumflex artery, which supplies more than 10% of myocardium in more than 95% of cases. Another important issue is plaque characteristics. Calcifications and fibrosis are abundant in this localization for sure. So we have to remember and we have to consider that without meticulous lesion and vessel preparation, the whole procedure might be a real nightmare, not only for immediate result, but also for late outcome. Starting the discussion of left main, we have to distinguish, let's say, localization of the lesion. So therefore, these three localization, ostium, shaft, and distal bifurcations, they are different, let's say, differs. It matters what kind of localization we supposed to treat, and we know from the literature quite well that the worst results in terms of percutaneous treatment are attached to distal bifurcation. We know quite well that intravascular imaging is very helpful. We know that we should use these devices, let's say, in pre-procedural phase, just to understand the real anatomy, sizes, length of lesion, plaque characteristics. This is very important also from this point of view, or this from position that calcifications today, which are recognized as biggest enemy of interventional cardiologists, now our armamentarium is growing. So we are able to choose the most effective device, starting from NC balloon through special designed balloon to intravascular lithotripsy, taking account, of course, and some kinds of ablations, high speed, orbital, and also laser. So this is very important to use these devices, and this is highly recommended from European Bifurcation Club. This is also important, especially for procedural phase of the precancerous treatment, because we should assess during two pullbacks from LAD and circumflex artery. We are able to predict the potential need for second stent inside branch, and we can choose a right provisional or two stents techniques based on these results as well. Here you can appreciate these cutoff criteria for minimal lumen area and plaque burden, which should be taken into account during these analysis. Also, this is a merit of people who are dealing with IVUS for left main stenting, that we know from Koreans papers that so-called Kang's formula is very helpful to understand when we should, when we are able to, or we can start to think about a completion of the procedure. Here you can appreciate this formula 5, 6, 7, 8. However, of course, this apposition and expansion of the stent is very important. The lack of good expansion, of course, makes a difference. But we also know from Excel study that the digits or numbers proposed by Kang's are not proper for Caucasian race. So we know from Excel that we should add at least 1 square millimeters to think about potential good results. This cutoff criteria 9.8 square millimeters seems to be very attractive. However, we know already from other literature that even 12 square millimeters, it's not 100% sure that this is optimal. So we have to add all of the information given by intravascular imaging devices to decide when we should start or to continue optimization of the results. In terms of part of protocol, we know that the most important part of the optimization is proximal optimization technique. Here you can appreciate relatively a fresh paper showing that for every primary and secondary endpoints for left main population treated with coronary stenting, it's most important. This is not the same for kissing balloons. There is no doubt that for two-stent strategy, it's obvious, it's mandatory. There is no space to discuss why not. But in terms of provisional T-stenting, we have a very not consistent information from the literature. However, as today Professor Dobrin already mentioned, all depends on the techniques, on the way of kissing. So the main, especially from the very well experienced interventional cardiologists, you can let's say listen that well performed kissing, at least not let's say hard the vessel sometimes is very important. Another story is regarding the most effective or proper techniques for distal left main bifurcation. So based on results of DK Crash 5, there is a strong information about the superiority of decay crash over provisional stenting. It's hard to discuss this topic. However, I especially try to show this slide because this sudden increase the primary target lesion failure in the provisional stenting group. It's not only my opinion, was associated with the shifted time of angiographic control, which was accelerated in the same moment of final assessment of the trial. Also, in this trial was shown that decay crash is superior not only for complex lesions but also for simple lesions. Based on these results in 2017 presented for our let's say for interventional cardiology field, there were a couple of proposals, couple of algorithms which should help in choosing the optimal method of stenting for distal left bifurcation. Here I can appreciate two of them. Just to simplify, since the lesion is simple and easy access for side branch, the provisional T-stenting should be chosen in the first as a first choice. When the lesion was complex, so-called complex, with a bad hard access to side branch, two stents techniques since the beginning should be taken into consideration, with a very stress on additional devices as IVUS and OCT for optimization, and of course for provisional T-stenting, functional assessment of side branch was also suggested. The other option takes into account the bifurcation angle, the narrow, and then the location of side branch lesions. Two stents. In other situation, provisional T-stenting was proposed. But of course, there was an answer last year from European Bifurcation Club. Here you can appreciate the scheme of EBC main trial, where was planned as a randomized comparison of provisional stenting versus systematic dual stent strategy for true bifurcation diseases. However, there was no one dual stent techniques. There were at least two. TAP and culotte mainly, with a stent from Medtronic Resolute Onyx. And based on these results, there was an algorithm proposed by European Bifurcation Club, taking into account provisional T-stenting as the philosophy, showing that inverted provisional and inverted two stents techniques are also a way of choice, and there was let's say as an equal proposal for two stents technique as decay crash. So there was not real only decay crash proposed in this proposition. And why? Because EBC main trial showed us there was no significant difference in primary and secondary endpoints regarding these two techniques, provisional and dual stent techniques. Based on this knowledge, we have to remember that still valid recommendation of European Society of Cardiology is this one, based mainly on syntax score numbers, and lack of diabetes. However, we have to remember that even European Society of Thoracic Surgery, where, let's say, we are not, there's still a debate due to the Professor Taggart comments to the 5 years result of Excel study. And we have also remember that recently published guidelines in the United States are, let's say, even they are much more liberal, not so liberal in Europe, and still there is no consensus between cardiac surgeons and interventional cardiologists, despite that the representatives of cardiac surgery were involved in the construction of the new guidelines. What is the problem? What should we take into consideration, thinking about the upcoming new guidelines? That taking into account the results of well-designed trials and 5 years of assessment, there was no the superiority of percutaneous treatment was only for stroke. There was a tendency and even superiority of cardiac surgery over percutaneous treatment in terms of repeat revascularization and myocardial infarction. Quite recently published another meta-analysis with almost 5,000 patients shows us that this is the true. The longer course of time after the percutaneous after the revascularization, the superiority of cardiac surgery is in a trend over the percutaneous treatment. Here, this is almost most recent paper showing that spontaneous myocardial infarction and per definition is much higher for spontaneous myocardial infarction is much higher for percutaneous group, but procedural myocardial infarction more for cardiac surgery. Stroke is almost equal, taking account 5 years of observation, and unfortunately repeat revascularization in superiority of cardiac surgery. Taking into account the mortality and cardiac death or cardiovascular death, we have to take into consideration the conclusion of this paper that theoretically, from statistical point of view, there was no difference taking around these two parts of type of revascularization. However, we cannot eliminate potential difference in favor of CABG also for mortalities. That is a very strong point which should be taken into consideration. The same trial, it was shown that this 5 years all-cause death in many subgroups of patients are in favor of CABG, only for younger people with acute coronary syndrome manifestation, with peripheral artery disease and a combination a left main and only one vessel involvement. This is a population with a good prediction of the PCI results. This is my proposal to all of you, that we should discuss during heart team what kind of revascularization is the best for a particular individual patient, and probably a new proposal of syntax 2 score, taking into account much more clinical data, giving us prediction of absolute risk difference for mortality for this two revascularization type, is able to help us in choosing this optimal way of revascularization. So in conclusion, let me say that qualifying a patient with different left main stenosis revascularization, just think twice. Heart team is the best solution. It shouldn't be, we are talking, of course, about chronic coronary syndrome patients. So we have to discuss, we have to take into consideration much more parameters than only anatomical one. Thank you very much for your attention.
Thank you. Have we comments from Imre or Lampros? No, Lampros is not there, sorry.
Yeah, I'm here. I'm
you're here. I'm sorry.
Yeah,
I see.
Yeah, sure, I'm here.
And,
but
any comment
Imre is the most senior. He has to start first.
Thank you, Lampros. But it's not a joy for me to be the senior. So congratulations, Robert. It was a great summary. I would ask two short questions to you. You mentioned IVUS and OCT, and of course we know that these are different. However, both of them are very useful for the better result and the prediction of the result. Do you think, although OCT is extremely reliable for this calcium scoring system, but do you think that for specifically for left main, does it have? I would mention just to measure the thickness of the calcium. So does it have in the real life real advantage over the IVUS, which is a very long time proved intravascular imaging, and it also can predict the long-term result of left main stenting. So OCT is a real indication for left main, or more theoretically? That would be my first question. And just a very short second question. You mentioned that in the DK Crash 5 study, also non-complex lesions were involved, and maybe the DK Crash technique was better for the non-complex bifurcations as well. If it's so, in my personal opinion, it could be only by chance, because I don't believe in the advantage of DK Crash in non-complex lesions. Otherwise, for complex lesions, it's a perfect solution. I agree. Thank you.
Imre, thank you very much. Excellent questions. I will start from the second one. You know, since the beginning, it was unfair. Let's say the design of the DK Crash 5 was unfair towards provisional T-stenting, because we are right. There was a very big crossover since the beginning from provisional T-stenting to DK Crash, at least 30% of cases, if I remember well. The author didn't take into account the knowledge which was gathered by European Bifurcation Club regarding provisional T-stenting. But you know, there was a thesis that used to, let's say, to show us that DK Crash is better. So this is unfair study for sure, and it will never happen again. I would say, for us Europeans, provisional T-stenting is a kind of philosophy. We don't exclude two stents technique, but we don't want to start everything with two stents strategy. Let's say in every bifurcation also for left main. And then I don't want to go into the details. I fully agree with you that based on our European experience, probably at least half of these simple lesions would never enroll in this study. This is for sure. However, what I would suggest to European Bifurcation Club, we should work on our attitude to the definition 2 study regarding complex bifurcation, because there are some differences in daily practice in Europe and this definition and daily let's say practice in Asia. So it should be taken into consideration. The question number 1, excellent as well. I'm old-fashioned. I am a big fan since the beginning of IVUS. I was one of the first who had the opportunity to work with this device. I love it. I know how many information we can gather, how we can avoid overuse of contrast media, for example. All of these facts and possibility of very good assessment of also proximal endosteum of left main tells me this is the best method. What is in addition, we should remember that all of the cutoff criteria are already checked with the let's say in the clinical field with the trials. For OCT, we have beautiful images. This is not a problem with distal left main because we can illustrate, I would say, everything very good. Recognition of or description of the images seems to be easier even than for IVUS. But we don't have these numbers. We don't know what is cutoff criteria for circumflex, for LAD, for point of confluence, and for main vessel, for example. So if you ask me what I do on daily basis, this is IVUS. But on the other hand, a lot of young people, industry, new trials force us to use OCT also for distal left main. So therefore, we should really concentrate right now on translation of the numbers to clinical parameters, telling us whether it's equally important or just only a toy for illustration.
Thank you, Robert.
Maybe we have to move to the next to the next presentation by Gianluca Rigatelli about treatment strategy. So reserve your question to him. Yeah.
I just want to comment something. We're speaking quite a lot of left main surgery and the PCI, but what is in real practice? Because just a comment in a minute. In our center, we have done more than 400 left main PCIs for, let's say, 8 years, and we are following them. And I would say that at least between 30 and 40% now, near summarizing the data, these patients, at least 30% have syntax score more than 31. More than 31. And these patients, some of them, we making our best effort to convince them to go for an operation, but they're refusing. And this is the reality, and it is not only here. There are patients coming from other centers where they were referred for surgery, and they are absolutely
This
convincible.
is the same in France.
This exactly is the same, and this is something that we should face. And
Italy too,
I would
sure.
say that if we go back, at least 20% even more of these patients, most of these patients, but most of the patients that we are treating have, they have age over 80. And we don't have data for these patients after cardiac surgery, finally.
For sure, for sure.
And this is a comment that we should do, because randomized trials are something very good, long term of follow-up. But what is the prognosis of patient that is 80 years old after 10 years in general? And how you can compare this and put them in one side as the randomized trials. This is just a comment which is really very, very, very often seen.
I agree with you. So, Gianluca?
It's a real pleasure to be here, even virtually, in this new 10th Jubilee Bulgarian Bifurcation meeting and course. And well, to speak about bifurcation strategy in left main PCI, and my talk is a treatment strategy. I hope to be clear and to share with you something of interest. We started with my usual case, a female with non-STEMI, 73 years old, a little bit obese, hypertensive, hypercholesterolemic, diabetic, private ictus, and STEMI with PCI and LAD for diffuse disease 6 months previously, and mild impairment of ejection fraction and renal function. The picture shows some not too much complex on the first look. Something here in the LAD before the previous stent at the ostium, big ramos with a long stenosis, and the left circ with a very diffuse disease. Using IVUS, we realized that the percent stenosis at the ostium was 80%, and we confirmed the 90% long stenosis of the big rams. So, what strategy for us talking about left main PCI? To me, strategy means a problem definition to describe the problem setting, and to solve the problem. In order to solve the problem, you need to define a plan at the different level, to be aware of possible plan complication, and to have in mind a plan B and plan C if we need to change strategy. Adapted to left main bifurcation PCI, problem description should include a clinical indication, clinical setting description, and left main complexity definition. So by angiography, FFR, IVUS, or OC. When considering clinical indication, our case, we have to be aware that the indication, the PCI for left main bifurcation are limited, but we have some space when we are talking about STEMI or unstable STEMI, and we are referred to the cardiac surgery or patient refuse makes a PCI the best option. But we have also to identify our setting. So we need or do not, we need the support. And we have this score is the simplest we can find in the literature. We evaluate ejection fraction less or more than 40%. And then throughout these kind of items with 1 point each, when the total score is above 3, we have to consider or strongly consider support during our left main PCI. But we have to also to define the complexity in order to build up a strategy. So Medina classification is okay for everybody, but now we have definition criteria, 1 major risk factor, side branch and diameter stenosis, and the length, or any other 2 minor risk factor among all these items. And in order to better imagine our case, we have to choose between high viscosity, if available, and in case we can probe our side branch after main versus standing with FFR. But we have also to define a plan pre-operatively, so we have to keep in mind some useful suggestion. Keep in mind that the outcome of left main PCI with modern drug-eluting stent depend on the strategy you use. Single stent strategy has a lower rate of MACE at TLR compared to two-stent strategy, but there is no difference in cardiovascular mortality, TLF, and stent thrombosis at 1 and 3 years, as you can see here. So if you need double stent strategy, go ahead. Double stent strategy is not too bad. It's not so bad compared as crossover on 1 and 3 years of follow-up. And again, you have to consider the length of dual antiplatelet therapy because this impact on outcomes. So if you use single, you can have a shorter DAPT. If you use double stenting technique, you have to consider extend a little bit more the APT in order to have a satisfactory outcomes. And also you have to keep in mind that thin is better than thick strats because the metal to artery ratio impact the outcome. And this colleague here in Italy found that when you use ultra thin, less than 18 micron strats, then there is no impact of metal artery ratio on outcomes in left main 1 versus 2 stent strategy. So, and here is another example, another meta-analysis we published recently, comparing old versus newer drug-eluting stent regarding the strat thickness. And you can see here the stent thrombosis and TLR are much better with the thinner strat. When you have in mind all the concerning about the stent technique, you can build up a strategy intraoperatively. So you have to be aware of all the measure that you can achieve with the stent that you have in your shield. And you can build up your strategy. So provisional crossover, T-stent versus TAP if you need to change. If you use it up front, double stent, you can choose between DK crash, inverted hour, non-inverted and TAPT or lot. The major concerning is we're ready to change strategy and to adapt your strategy to the changing situation on the team. And here we have the previous case. So we plan to go for an uninverted D between Ramos and LAD left main. We just pre-dilate the left circle with for application of a drug coating balloon, and then we pre-dilate very well the Ramos, but searching the proper position for uninverted D, so very slight, small one ring protrusion of the side branch stent into the left main. Oops, we choose or we lost the stent. So here you have the stent lost without the wire because my colleague pull out the wire, and so we have to rewire and to change the strategy. So we considered that the best way was to convert our technique in decay crush. So we rewire and predilate with very small balloon, CTO balloon, and then we go for first kissing. And then we go ahead with the standing technique. So standing dura of the left main versus LAD, second part, second kissing, and the final part. And then, and this is the final result, and you see that everything is fine. Ramus is widely open, left main is widely open, even the left circuit is not so bad, consider the diffuse disease. And so strategy is a simple word which defines a complex process. The process should be managed in a scientific but practical way. A good strategy should be split in complexity definition, definition of a plan, anticipation complication of that plan, and definition of alternative plans. So you have in mind then when you adopted this definition to a left main PCI, any strategy should include a clinical indication consideration, anatomy, complexity description, choice, 1 versus 2 stand technique, anticipation complication, and definition of alternative technique if needed. Thank you so much for the chance you give me to share with you my idea, and a big hug, a big virtual hug to Valerie, Dobrin, and all of you. I miss Bulgaria, I miss Sophie. I deeply hope to shake your hand and give you a big hug in person the next year. So thank you so much.
Question or remark for Gianluca?
Now it's the time for the junior, huh? I suspect.
I'm not so junior. I was junior 10 years ago.
No, junior for me.
Okay.
It's a joke because I said before that Imre is the senior, now I'm the junior.
Okay, that's good.
Okay, so don't take it personally. It's not for you. So I think first of all, I would like to congratulate you for your presentation, where you put a lot of things of how we can deal with this complex scenario, and also congratulate Gilles before for his overview about about revascularization of left main disease. And I think that for the whole session, we had two things that we considered. One is how the revascularization should be done, CABG versus PCI. And the other is if we select PCI, how to do it. That's the main thing. Now for all this thing about CABG versus PCI, there's a lot of noise and what is better and what is worse. And I suspect from all this noise, there's something that we should not be as liberal as we thought we should be 2 years ago about revascularization of PCI. Should be so liberal to use one or the other technique. That's the one thing. The other is that all this data come from studies that they have low surgical risk. Yeah. And indeed, the majority of our patients is of high surgical risk. So I'm a bit, and that's what I suspect Dr. Gelef implied when he said I had all my 80 years old patients. By definition, a high risk patient, and possibly a lower expectation regarding mortality or prognosis of survival in somebody who's 85 or 90 or 83, and that's what the type of patients that we're dealing with. So in my view, something has to be very cautious about that, and it's a very complex problem. What you should choose is the anatomy, is the vessel quality. For example, I have many patients that turn down by surgery because they have bad surgical targets in the end, and they're very difficult to be treated, and also comorbidities. All these patients with comorbidities. I've seen you saying all these patients that they need circulator support, all these things that they imply comorbidities. We judge PCI with the syntax, with complex anatomy, with the syntax, and STS or Euroscore for surgery, which is not is comorbidities, is how bad the patient is, how ill the patient is. There are two different things. And for me, PCI has a lot of space because we're dealing with patients that they have lots of comorbidities. That's my general comment about that. And that's where the heart team is very important because it's center specific. You have very good surgeons in one place and possibly not very good interventionists and vice versa. And every center has to make its own standards. It's not something which should be unique and so unified across every country and every center and for every patient. And that's why heart team is very important decision. Now about the how.
Yeah, sure. Maybe just a short remark. Maybe you have to ask to add to your discussion point in your hospital the reported result of surgery and the reported result of PCI, because the comparison has to be also local or regional or national. But we know that the result, for example, in Excel, in PCI, the result of North American PCI and European PCI is not the same. They have a higher rate of reintervention in US. So we can imagine that you have exactly the same in your place or in the place of Robert. When we discuss as a heart team, we don't have to go to the heart team discussion asking the surgeon what they want to do. You know, you have to say, okay, how are the results this year?
Yeah, that's why I'm saying it's specific. And now we pass the time after having heart teams for a long time. It's not now when we go to the heart team that we sort of fight with each other. We know each other very well because we've been sitting in the same room for a long time now and we are discussing. And we know now and we learn from each other than fighting each other. That's how I found it in my place. Now it's the discussion and the conclusion and the consensus. It's much easier than it used to be a few years ago.
Yeah.
And I think that everyone faces.
Let me share my comments. That was great what you said right now. But just to express how hot and delicate is this topic, I would like to remind you the syntax trial. There were randomized part and the registry part. Registry part, the patient was sent for cardiac surgery. Have you ever heard about the results of this group? No. This is the answer. There is no good results for cardiac surgery in this group of patients. Right now, with the new technology, with our knowledge, new devices, we are able to do that much better than it was in 2006, 2007. This is important message which should be taken into consideration.
I agree.
So we can spend a lot of time to discuss more, but
now
I think we have to move. If I'm not wrong, I'm looking to Dobrin. I have to move. We have to move. So to the next
Thank you.
But you know, I share your opinion. I share your opinion. We don't have to ask surgeon if we can dilate the patient. You know, we have data, and during the heart team, or even on national position, you may discuss the result of your surgeon, not the result of a very good surgeon in Cleveland Clinic. You know. So this is my opinion. I'm sure you share. I'm sure you share it. So you have to be proud of to be interventional cardiologist.